Have you ever had that like sudden pain right in your knee or thigh during a workout maybe, or even just walking downstairs?
Mm-hmm.
Or maybe it's more that nagging ache, the one that just hangs around and makes running or squatting,
Mm-hmm.
well, pretty unpleasant.
Yeah, that sounds familiar to a lot of people, unfortunately.
If it does sound familiar, you're definitely not alone. So today on the deep dive, we're really digging into two really common but often confused lower body issues: quadriceps strains and quadriceps tendinopathies.
Right.
We've sifted through a bunch of clinical guidelines, research papers, notes on athletic injuries, basically trying to get clear on what's actually going on here. And our goal, really, is to get past those surface-level explanations. We want to unpack what makes these injuries different, how doctors figure out which one it is, and crucially, the best ways to treat them.
Yeah.
The aim is for you to walk away with some real actionable insights. Not just what they are, but why knowing the difference matters for getting better and, keeping your joints healthy long term. Exactly. It's about taking all this complex medical stuff and making it clear, quick, and actually useful for you. So, okay, let's unpack this. First things first. The quadriceps itself. It's not just one muscle, is it?
No, not at all. It's a really powerful group. 4 distinct muscles, actually. You've got the rectus femoris, then the vastus lateralis, vastus intermedius, and vastus medialis.
Okay.
And they all come together, forming the quadriceps tendon, which attaches right onto the top of your kneecap, the proximal pole of the patella.
And its main job?
Primarily knee extension, straightening your knee. And it works opposite to your hamstrings. It's the antagonist.
Got it. So within this big muscle group, we see these two main injury types: strains and tendinopathies.
That's right. 2 very different beasts. Let's start with the strain. A quad strain is acute. It happens suddenly.
Okay, like a specific moment.
Exactly. Often it's from a really forceful, eccentric contraction. So think about your muscle acting like a brake, contracting while it's lengthening.
Like lowering into a deep squat, maybe? Or landing a jump?
Perfect examples. Knee bending, hip extending under load, or sometimes just from overstretching the muscle too far too fast.
And you mentioned one part is more vulnerable?
Yeah, the rectus femoris. That's the one most commonly strained because it's unique. It crosses both the hip and the knee joint.
Ah, okay. Double duty makes it more susceptible.
Precisely.
Yeah.
And these strains usually happen right where the muscle fibers blend into the tendon, the musculotendinous junction.
Okay, so strain, sudden event. What about tendinopathy? How's that different?
Quadriceps tendinopathy. It's usually a more chronic issue. It's a degenerative change happening in the tendon itself.
So not a tear, but more like wear and tear?
Sort of, yeah. It's typically an overuse injury. We
Right.
see it a lot in athletes, often linked to repetitive loading, constant stress, lots of knee extension movements.
Like jumping, running, cycling maybe?
Absolutely. Especially if someone suddenly ramped up their training intensity or changed the type of activity they're doing, the pain tends to build up gradually.
Okay, gradual onset versus sudden. And the symptoms people actually feel. Where does it usually hurt for either of these?
For both, actually, the pain is very often localized right at the top of the kneecap, that proximal pole of the patella we mentioned.
Right there.
And it almost always gets worse with activities that really load the quads. Squatting, jumping, climbing stairs, even sometimes just getting up from a chair.
Sound familiar? I bet it does for some listeners.
Yeah, that specific spot is a key indicator.
Okay. So someone feels this pain, they suspect something's up. How do doctors actually pinpoint whether it's a strain or tendinopathy? What's the diagnostic process?
Well, it usually starts clinically, meaning the doctor relies heavily on your symptoms and a physical exam.
Makes sense.
With tendinopathy, like we said, the pain often comes on insidiously, gets progressively worse, maybe started as a dull ache.
Right.
Whereas strains are, boom, acute onset, sudden sharp pain usually.
Okay.
During the exam, the doctor will palpate, feel around for tenderness at the bottom of the quad muscle at the top of the kneecap.
Checking those key spots.
Exactly. With strains, you might also see some swelling, maybe even some bruising.
Yeah.
And there's almost always pain and sometimes noticeable weakness when you try to straighten your knee against resistance.
Okay.
And sometimes, with a more significant strain, like a grade 2, the doctor might actually feel a little dip or defect in the muscle.
Wow. Okay.
Now, here's an interesting clinical sign. The straight leg raise test is typically okay. You can usually still lift your straight leg off the table.
But
if you can't lift your leg with the knee fully extended, that's a bit of a red flag. It might suggest a more serious injury, like a complete tear of the extensor mechanism.
that's a really important distinction then. Okay, so clinical exam gives a lot of clues. What about imaging? Do doctors usually need pictures?
Sometimes, Radiographic evaluation often starts with plain old x-rays of the knee.
And what can they show?
Often they look completely normal, especially early on. But sometimes you might see things like enthesopathy changes where the tendon attaches to the bone, or maybe little bone spurs, osteophytes at the top of the patella.
Okay.
You might even see calcification in the quadriceps tendon itself, or something called patella baja. That just means the kneecap is sitting lower than usual, which can be a sign of a complete tear.
So x-rays can offer some hints, maybe rule out other bone issues, but for the tendon and muscle detail.
That's where we move to MRI, or ultrasound. An MRI. Well, this is where it gets really interesting, especially for athletes.
Oh, yeah.
MRI studies have shown signs of tendinopathy, actual changes in the tendon in people who have zero symptoms, no pain at all.
Really? Like, how common is that?
In some studies, like with basketball players, it's been reported in up to 90% of them.
Wow. 90% have signs but no pain.
Yeah. It's pretty profound. It tells us our tendons might be undergoing these degenerative changes way before we feel anything.
That definitely changes how you think about prevention and listening to your body, doesn't it?
It really does. Proactive care becomes even more important. And ultrasound is great too. It's very good at looking at tendons. It can show specific things like changes in echogenicity, basically how the tissue looks on the scan. It can pick up neovascularization, which is new blood vessel growth that shouldn't really be there, tendon thickening, actual fiber disruption, or even small hematomas if there's a partial tear.
It's fascinating that those changes can be happening silently. Okay, so once the diagnosis is a clear strain or tendinopathy, what's the usual recovery plan?
Well, the good news is that for almost all cases of both quad tendinopathy and strains, non-operative treatment is the first line. It's the cornerstone.
So avoiding surgery if possible.
Absolutely. The main things are relative rest and activity modification. That means backing off the activities that aggravate it, reducing the load.
Makes sense.
And physical therapy is absolutely crucial. Huge focus on eccentric strengthening exercises, those lengthening contractions we talked about, and also stretching the quadriceps.
Okay, PT is key. Anything else?
Yeah, there are adjunctive therapies. Things like iontophoresis or phonophoresis, which use electrical current or ultrasound to deliver medication through the skin. Therapeutic ultrasound itself for tissue heating, and good old ice therapy can help manage symptoms.
Right. So conservative first. But, is there ever a worry that sticking only to non-operative treatment for really stubborn cases might, drag things out or not lead to a full recovery for some people? What if that stuff just isn't cutting it, especially for that chronic tendinopathy?
That's a really valid point. And yes, sometimes conservative care isn't enough. For tendinopathy that just isn't responding after a decent trial of PT and rest, there are more advanced non-operative options.
Like what?
Well, injections around the distal quadriceps tendon are considered, but it's important we generally avoid corticosteroid injections here.
Why is that? Risk of weakening the tendon.
Exactly. Potential for tendon rupture down the line. So instead, the focus is shifting towards biologic therapies, things like autologous whole blood, platelet-rich plasma PRP, or maybe even stem cell injections. The idea is to stimulate healing.
Okay, using your body's own stuff. Any other non-surgical options?
Needle tenotomy is another one. Basically, using a needle to create tiny disruptions in the tendon, again, trying to kickstart that healing response.
And how well do these advanced things like PRP actually work? Is there good evidence?
Yeah, there's growing evidence. PRP, for example, has shown better results than dry needling, just using the needle without injecting anything at the 12-week mark.
Okay.
Though interestingly, that difference seemed to lessen by about 6 months. But for more severe cases, what doctors call Blazina grade 3 tendinopathy.
Which means it's pretty bad or persistent.
Right. In those cases, PRP has actually shown better results than physical therapy alone for reducing pain and helping people get back to their sport at the 6-month point.
So it's definitely an evolving area, regenerative medicine really pushing forward.
It absolutely is, offering hope for these tougher chronic tendon problems.
But even with these advanced options, some people still don't get relief. When does surgery finally enter the picture, and what does that look like?
Surgery for quadriceps tendinopathy is really held back. It's reserved for cases that haven't improved after at least 3 months, sometimes longer, of consistent, good quality conservative treatment.
Okay, it's definitely not the first step.
Not at all. One situation where surgery might be needed more often is calcific tendinopathy, where there are actual calcium deposits in the tendon causing pain or mechanical issues.
Okay. Makes sense.
As for what surgery involves, there isn't one single agreed upon best technique right now. Options range from minimally invasive arthroscopic procedures to open surgery. Usually the goal is some form of tendon shaving or debridement, cleaning up the damaged tissue.
Gotcha. So after the initial treatment phase, whatever it might be, what's the journey back to full function look like? Let's talk rehab, maybe starting with the strain first. How do you get back safely?
Right, for a quad strain, rehab starts pretty quickly after the injury. Usually a brief rest period, maybe 3 to 5 days, just to let things calm down initially.
Okay.
Then it's straight into physical therapy. The focus is initially on gentle stretching to restore range of motion in both the hip and the knee. Then you gradually, carefully progress to strengthening exercises.
And getting back to sports or activity, how do you know when it's safe?
That's guided by pain tolerance and how well you're functioning. But the absolute key criteria are: you need to be completely pain-free during activity, you need full range of motion back in the hip and knee, and your strength needs to be nearly equal to the uninjured side.
So no rushing back.
Definitely not. That's a recipe for re-injury. Patience is critical.
Okay, that covers strains. What about the long-term outlook for that chronic tendinopathy? Do people usually get fully back to normal, or can it be something that kind of lingers?
That's a really important question. While non-operative treatment often provides good symptom relief for quadriceps tendinopathy, it's true that some people do struggle with persistent pain and some functional limitations long-term.
So better might not always mean completely gone.
Exactly. It raises the question of what we really mean by long-term recovery. Is it just no pain, or is it full, unrestricted function? There was a study, Kitunen et al., that found athletes who had had quadriceps tendinopathy still reported more knee pain during things like squatting years later.
Oh, wow.
And unfortunately, they also had higher rates of retiring early from their sport compared to athletes who hadn't had the injury. So while many improve significantly, it can have lasting effects for some.
We've definitely covered a lot of ground here, from, understanding that key difference between a sudden strain and that nagging tendinopathy to how doctors diagnose them using exams and imaging like MRI, and then exploring the whole range of treatments, everything from just rest and PT to those newer injections like PRP, and even surgery as a last resort. It really shows how complex these seemingly common intervals can be. So, what's the big takeaway for listeners? Athletes or just active folks?
I think the biggest thing is recognizing what kind of injury you might have.
Yeah.
Getting it checked out early and getting the right kind of rehab for that specific issue. Understanding strain versus tendinopathy really gives you power in your recovery.
Yeah.
And it definitely helps prevent it from coming back or becoming a chronic problem.
Yeah.
Knowledge really is power here for managing your body.
Absolutely. And maybe final thought for everyone listening. Think about your training load, Are you increasing things too quickly? And really try to listen to those early subtle signals from your body. Don't just push through the whispers until they turn into shouts.
That's so true.
Maybe being more aware, more proactive about how you load your muscles and tendons. Maybe that's the best way to stop these things from becoming chronic issues in the first place. Thinking about health proactively, not just reacting when pain hits.